Hello, my name is Ronald Torres. This is a webcam presentation for Adult Gerontology Advanced Clinical Practicum, Nurse 5501. I have your unique case of the 78-year-old female. She has a past medical history of a COPD. She was using 2 liters of oxygen at home, type 2 diabetes, coronary artery disease with stents times 2, history of hypertension, history of dementia. The chief complaint here from the patient was that she was a fall at home and altered mental status reported by the family. The report was received from the daughter who found the patient and found her to be confused and that she was incontinent with stool and urine. EMS was called, BGL was checked, alertness was checked as well according to EMS report. Patient was brought into the ER. Something the daughter did know upon evaluation in the ED is that patient drinks plenty of water, lots of water, but does not eat a lot. Unknown reason for the drinking of lots of water, perhaps dehydration. The patient does live at home alone, and HVAC, heating, and the ventilation and air conditioning may not be the best. Patient evaluation in the ED showed a CT that was negative. CT of the spine was also performed and also negative. Other workup also revealed unremarkable CBC, except for a white blood cell count that was at 12.9, and CMP was unremarkable. However, the sodium was shown with a 121. Calculated osmolality was shown at 259. The urinalysis was negative, and patient had normal liver function, and troponin was 0.03. During the evaluation in the room, the patient noted to be cold. The mentation of the patient wasn't great, so the history wasn't strong from the patient, but according to family, that there was no complaints of a headache, dizziness, or blurred vision. Some moments of conversation with the patient. Patient did not know why she was in the hospital. She could state her name, and date of birth, partially, but was not alert to event. Her vitals were as follows: heart rate is 73, 198 or 86 BP. Her respies were really high in the 20s and 30s range. No reports of fever, shortness of breath, palpitation, abdominal pain from family or patient. Patient has a long list of meds that she was taking based on her history: pantoprazole, 40 milligrams daily. She takes Novolin R subcutaneous in the morning and at night. Humulin insulin, Humulin N, 80 units, BID. Also takes aspirin chewable daily. Plavix, 75 milligrams for that coronary artery disease and stent. Amlodipine, 5 milligrams daily. Atorvastatin, 80 milligrams daily at night. Losartan, 50 milligrams daily. Albuterol for the COPD. She uses 2 puffs inhalation for shortness of breath when she's in that situation. And she also takes metformin, 1,000 milligrams BID PO. She does have allergies to penicillin. Her surgical history includes colon resection, hysterectomy, cataracts, and ankle surgery. What I gathered from the family was that the father of the patient had a history of type 2 diabetes and also had cabbage at some point in his life. Her mother had stomach tumor that was removed, according to the family, and that mother also had myocardial infection. The review system was unable to be obtained based on the patient's confusion. Some of the answers I did receive from the patient I could not fully rely on. I had to receive from the patient's family. As far as the physical exam, patient constitutional-wise, she was sitting in bed, no acute distress. She was alert to, once again, person and date of birth, partially, but disoriented to place, time, situation. Otherwise, she was pleasant. Her head, normal cephalic, atraumatic, no deformities, no lumps, no tenderness, no falls directly to strike of the head. Facial expressions seem to be appropriate, symmetrical. For stroke, no signs. as far as facial asymmetry. Her eyes were parallel, no edema. Her sclera was yellow, conjunctiva was pink. There's no swelling, no nodules. Her pupils were equal, round, reactive to light, accommodating. Her ears didn't show any lesions, no tenderness to the auricles of both ears, throat and mouth. Oral mucosa seemed pink, moist. The tongue was midline. Her nose mucosa was pink. Septum was midline, no sinus tenderness. Her neck seemed supple. No lymph nodopathy, trachea was midline. Cardiovascular wise, she was RRR, regular rate and rhythm. No JVD, no murmurs, normal S1 and S2 audible. Clitoral auscultation bilaterally, no wheezing, no rhonchi, no rails. Patient does use 2 liters, nasal COPD with a history of. Bowel sounds were normal. All quadrants were auscultated and heard. Abdomen was flat. Soft tube palpitation on tender. Genitourinary, patient was incontinent. No Foley was in place. Skin was intact, no rashes, no wounds. Noted musculoskeletal, she had no deformities, no edema, no cyanosis. Biologically, she was alert and oriented ×1. I call it just 1 at the point, since she couldn't get the date of birth. Her gait was not tested since she was in the stretcher, and her sensation seemed to be intact when I would ask her questions. Extremities were fine. There were crap refills less than 2 seconds. Bilaterally, dorsal pedis pulses, radial pulses were palpable. Her sodium was shown to be at 121, potassium 3.8, chloride 82, CO2 20.4, BUN 12, creatinine 0.56, glucose 239. White blood cell count was elevated, 12.9, hemoglobin of 14.2, hematocrit 44, platelet 258. Once again, the CT of the spine and the neck was shown to be negative. The assessment and plan for this patient is one thing, just based on her breathing, high respiration count, also even with her history. But I still included acute or chronic hypoxic respiratory failure with supplemental oxygen having to be used. She has a history of COPD. That was another part of the diagnosis. Considering her serum osmo and her sodium, have her as hyponatremic. With the serum osmo that came back, she was hyperosmolar hyponatremic. Also leukocytosis with that WBC of 12 can also be secondary to dehydrations, but something to note. Considering her respiration, she's on oxygen, even though CPD. You want to make sure she's not hypoxic due to pneumonia infection, even though CT, the chest X-ray at this time was pending. Later did prove that there was no acute cardiopulmonary disease. But at the time of the note, I was not sure. She did have hypertension that was noted on type 2 diabetes, for hyperglycemia, coronary artery disease. I've also put her down as acute and chronic metabolic encephalopathy, just based on her confusion. Ultrasound that it could be possible to what she's suffering from. So my plan for her was to continue on supplemental oxygen, continuous SpO2, RT to evaluate and titrate the SATs if anything was less than 88, but she can stay between 88 and 90. Wean off is tolerated. Doing nebs to be ordered, scheduled nebulized treatments with budesonide and Bruvana for her. Started her on IV fluids. The easiest thing for her to do was start on 100 ml per hour and making sure we do serial sodium checks every 4 hours. We were going to avoid any rapid correction and any osmotic demyelination syndrome for her. Just make sure that we do not increase more than 70 milliequivalents in the first 24 hours. We were waiting to obtain lactic acid, procalcitonin, and a SARS test for COVID, just because of the high respiration and also the oxygen use. And we'll continue to monitor with the daily CBCs since she had the white blood cell count that was increased. Continue her home meds for our hypertension, amlodipine, losartan. We put down hydralazine IV PRN for systolic that was greater than 160. Continue with start acute checks every morning and night, and insulin moderate sliding scale for her. especially or altered mental status. We'll make sure she wasn't hypoglycemic, which she wasn't. If anything, she was hyper. Um, but with something to keep in note, because it was hyper, you can also you have to reflect on the serum osmo. If that was a reflection to be high, which it wasn't because it was actually low, high glucose, low sodium could be a case of hyponatremia that's caused by a high osmotic count from the glucose. Can also happen with ETOH as well. Just continue watching this patient to monitor, admit to the telemetry for, and add her on fall and aspiration precautions. What makes this so unique is after we receive the serum osmo, consider the nephro consult, or in the beginning was to consider. Eventually, we did put it in, just because we wanted to. After the serum osmo showed vulmic, she wasn't hypervolemic, she didn't diuresing, she wasn't volume decrease, so she didn't need intravenous fluids. She didn't show any fever. She didn't show any skin trigger their tenting or things to that nature. So the couple things that I've picked up within my studies and with my roundings is an acronym called stated as RATS, which is renal tubular acidosis, Addison's disease. Check the thyroid for TSH, and then SIADH. Upon nephro consult, we end up finding out that her urine sodium did reflect that she's possibly etiology could be SIADH. So we were at the point we based on the recommendation of nephrologist, she was getting sodium chloride tablets, TID. I had this patient for 2 days. She was a very interesting case. I think the electrolytes are the one of the trickiest ones, how to follow, making sure not to overcorrection. Hyponatremia is probably the hardest to do between them both. For hyponatremia, especially if you overcorrect it, because you can cause the spastic quadriplegia if you overcorrect it, and it is irreversible. So very interesting case. I hope that I brought some insight to it, and looking forward to anybody's comments on this. Thank you.